there. But we will go in depth with this topic. So when you have a high risk pregnancy or uh, you have morbidity or mortality in obstetrics, and you end up having mortality, okay, the question will always pop out in mind. Was it preventable or is it non-preventable? Okay. Was it really not our fault? Are we at fault or not? Or did we really do our part as doctors or physicians to prevent this kind of complications in a mother? Okay. So bear in mind. So later we will answer this question at the end of the lecture. So the terms are used interchangeably for your consumptive coagulopathy. Sometimes they call it defibrillation syndrome or consumption of your fibrin, or others would call it disseminated intravascular coagulation. However, they have specific distinction. Okay? It means that when you already have the term DIC or your disseminated intravascular coagulation, this one occurs more in the latter part or severe part of your consumptive coagulopathy. So there are certain events that happens. Okay? One is your actual consumption of the coagulants within the intravascular tree. So this one results in consumptive coagulopathy. So you consume all the coagulation factors. Next is where there is massive loss of coagulants from hemolysis. Okay? And then it results in dilutional coagulopathy. So for the pathological, please turn off your mic. Okay? So for the clinical pathological pathway, so for your consumptive coagulopathy, okay, it progresses into an systemic intravascular activation, and then your hemostasis, okay, normal hemostasis is disrupted. Okay. Naturally, there should be a balance in the intravascular system between the procoagulants and the anticoagulants in the blood. Okay, so as not to be hypercoagulable or not to be hypocoagulable. And you know that during pregnancy, okay, we should be at least at a little bit more of the hypercoagulable state, okay, but not too much in preparation for delivery because it's a natural thing. We have blood loss during pregnancy or during delivery. Okay? So you will really incur blood loss. And so not to incur a lot of blood loss, okay, the body has its own mechanism to at least a little bit make it more like guarding, okay, guarding the intravascular system not to become hypocoagulable. So when there is loss of balance, okay, these are the things that happen. There's ineffective balance of the natural anticoagulant, widespread fibrin deposition, and there you could also end up having multi-organ damage, which we do not want to happen. So DIC, you will usually hear that when you are in the ward or you're disseminated intravascular coagulation. It is really problematic in pregnancy. And we don't RG Sembrano. RG Sembrano, please off the and your baby is crying. Please take care of the baby. Anyway, so consumptive coagulopathy in pregnancy is problematic. So about 0.03 or 0.35%. It's really a dreaded complication and you want that to happen when you are the ones in duty at the OB ward or you're the one in the ER. You don't want to see these kinds of patients. Okay? So in 1901, Dilly described temporary hemophilia. Okay? So that is the start where they noted there is DIC. So for the consumptive, it is a consumptive thrombohemorrhagic disorder. So this DIC can be seen in cases like your abruptio placenta. I hope it was already discussed. I think it's already discussed during your OB1. Okay, septic abortion or infection after an abortion. It can also occur in chorioamnionitis. Those with amniotic fluid embolism, PIH, or pregnancy induced hypertension, okay, or your preeclampsia, eclampsia, okay, or your HELP syndromes, okay, and then your intrauterine fetal death. So, hypofibrogenemia is the previous term used for DIC. It is an intermediary mechanism or disease complicating a multitude of disease. So, it's really difficult to conduct clinical trials because it has complex clinical presentation. One symptom or sign could not always be present in certain patients, so they vary in presentation, and it has an unpredictable course. Sometimes it's just mild, then suddenly, a few hours, your patient succumb to death. So it depends. Okay? Sometimes it could be severe, but after a few days, your patient has already recovered. So it will depend on the patient to patient scenario. And there are various therapeutic measures done. So for the etiology in the Philippines, still we don't have an overall incidence for that. So as of the moment, we are still uh, like making our statistics collection better in the Philippine Obstetric and Gynecological Society. Okay, so I hope in 5 years' time we would come back and tell you the overall incidence. Okay, at least more clear cut statistics regarding this in the Philippines. But in the US, in large hospitals, they reported that it occurs in 1,000 admissions. Okay, this is in general. Okay, it includes other specialties, not only in OB, could be in surgery, medicine, pedia. So it could occur in 1 in 1,000. And mostly it is due to infection, which occurs in about 30 to 50% of the IC cases. So there are no age, racial, or sex predisposition. Complication of obstetrical, it can be obstetrical and non-obstetrical causes. So it is described by Jacobson that 50% of DICs is due to obstetric complication. And the most common cause for DIC in pregnancy is an acute obstetrical hemorrhage. That's why we don't want our patients to have a lot of blood loss. Okay? So during prenatal period, we already have to prepare, okay, for the possibility of this. So number one that we have to remember, as I was also taught when I was a resident, is anticipation. Anticipation that hemorrhage could occur during or even before delivery or even after delivery of the baby. So how common is DIC in pregnancy? So the incidence is not well defined and ranges about 0.03 to 0.35%. So the OB leading etiologies includes placental abruption, especially when associated with a stillbirth or IUFD in developed countries. While us in the developing countries, the most common cause is preeclampsia and also retained stillbirths. Okay? So for sometimes those who have dead babies inside and they don't go for check-up or admission, they still could end up having DIC. That's why every time we have IUFD patients, we should admit them and at least hasten, or we have to already make it fast for them to deliver the unborn, stillborn baby so as not to develop DIC. And we will be able to monitor them laboratory-wise. They're in the ward. So we have to admit those patients. So how do we maintain the hemostatic balance? So what are the effects? Okay? So we can maintain the hemostatic balance by these four processes. So you should have one, unobstructed blood flow. Why? Because it dilutes activated coagulation factors. Okay? So next is humoral factors. Okay, there are inactivated stable coagulation factors. And then there should be an intact reticuloendothelial system, or your RES, which removes products of coagulation and clot disintegration. And the presence also of prostacyclin from endothelial cells. This would inhibit abnormal platelet aggregation. So all of this should be present to have a normal hemostatic balance in pregnancy. So pathophysiology, okay, normally we have a balance, okay, between low grade activation of coagulation factors and platelets and neutralization of activation products in the circulation. So destroying the balance would lead to intensive activation of hemostasis, hypercoagulable state, which would end up to having massive thrombosis, okay, and with diffuse fibrin in the microvascular circulation. So coagulation factors and platelets are consumed. This could lead to massive bleeding and further aggravated by your secondary fibrinolysis. So triggering mechanisms, we have the two pathways. We have your intrinsic pathway and extrinsic pathway. I think this topic is already handled in your pathology subject, and it is also included in your in pathology, in your serology, blood banking topics. Okay, so we'll just go through it, and we will have uh, clinical correlation with these pathways. So endothelial damage could be damage through the intrinsic pathway, as observed, for example, in septic abortion or corium amnionitis. Okay? So if you note there, it's because of a severe infection. And then for the extrinsic pathway, massive tissue injury with the entry of a procoagulant material. So you would be needing a procoagulant material before you could trigger the extrinsic pathway. So what are the examples of these cases? You could have abruptio placenta, amniotic fluid embolism, a retained dead fetus, or those who would undergo saline-induced abortion, in which this one is not even allowed here in the Philippines. So most probably we do not have this saline-induced abortions in the Philippines. So abnormal intravascular platelet activation, it's another, actually it's not a pathway, but it's another way where you have you can trigger the patient to have DIC. So what are our examples? In your thrombocytopenic purpura cases, so as you see, it's the affected element are your platelets. In malignant hypertension, especially if you have decreasing platelets in your, if you have heard the HELP syndrome, okay. Again, what is HELP syndrome? I will call so that I know you are listening. Doctor, the first one in my picture here is Elijah Cunha. So what is HELP syndrome before we proceed?
HELP syndrome stands for the hemolysis, elevated liver enzymes, and low
Yes.
platelets po.
Okay, so with the LP there, the low platelets, as you see, the platelet could be affected in the presence of your hypertension, especially in your HELP syndrome. Okay? And then your pregnancy-induced hypertension still, especially if it's severe, okay, you could have decreased platelets in those scenarios. Okay, so thank you for that answer. At least you know what's HELP syndrome. The last time I lectured this one, they don't even know what's HELP syndrome. So as you see this pathway here, when you have an extensive, sorry, when you have an extensive activation of your coagulation pathway or factors, you could have endothelial damage, tissue injury, and platelet activation. So, endothelial damage, tissue injury, platelet activation, which would lead to your massive thrombosis. Okay, and then you can see there you may have the fibrin deposits in your microcirculation, which could cause infarction or even cause hemolysis. So, if you have massive thrombosis there, you render your patients in the hypercoagulable state, and then further, they would lead to consumption of coagulation factors and your platelets. So, pag naubos, if you consume that, and you did not replace that immediately or properly or timely, then your patient turns to have your in the hypocoagulability state. Okay? So if you have bleeding and you are again in the hypocoagulable state, they will lead to a more bleeding. So you end up in massive bleeding. Okay? Massive bleeding in a sense that there could be vaginal bleeding or bleeding in the injection sites or even in the surgical sites, okay? And sometimes you could have nose bleeding, okay, etc., or gastric bleeding. And eventually, if the blood is not properly replaced, if there's inability of blood products, then the patient could succumb to death. Okay, another here is your that minor pathway where extensive activation occurs. You could have the with the activation of your prekallikrein, high molecular weight kininogens, again, you activate your fibrinolytic system, causing secondary fibrinolysis. Again, it ends up having more hypocoagulability state, again, ends up in massive bleeding, in which we do not really want to happen. Okay? So at this point, okay, this point, if possible, we have to prevent these kinds of complication to happen. Okay? At this junction, we have to really prevent that to further progress so that the patient would not die. So endothelial damage, so DIC complicates severe infection due to the potent endotoxins that damage the endothelium. So mediators increase, which are included includes the following: interleukins, your toxic necrotic factors, your platelet activating factors, leukotrienes, and thromboxane. Um, Damage of vessel walls and subsequent exposure to collagen activates the contact factor 12, initiating the coagulation cascade leading to a clot formation to your intrinsic pathway. So the intrinsic pathway is a slow process, and coagulation factors circulating in the inactive form are activated. So this is the algorithm for your intrinsic pathway. Example, you have your septic abortion. It would lead to an endothelial damage. So there is contact activation in your factor 12. Okay. As you can see, for the clotting factors, they are written in numerals. Okay. So factor 12, and then leads to, if it's activated, your plasma thromboplastin antecedent, factor 11, then factor 9, leading to your factor 8 to be activated. including your platelet factor 3 and your calcium. Then your Stewart power or your factor 10 and your factor 5 will be activated. Then if that happens, the prothrombin, okay, with the prothrombinase in the common pathway will be activated to become your thrombin, and the thrombin will also activate the present fibrinogen to become a fibrin, or that is your blood clot. Okay? So that's what happens in your intrinsic pathway. So since it undergoes all of this pathway until it goes to the common pathway, it is a slower process. For the extrinsic pathway, okay, massive tissue injury occurs, and it is known as opposite your intrinsic. It is a more rapid process. So materials come from the tissue not ordinarily present in the bloodstream. So kaya nga extrinsic, it comes somewhere. The activating factor not present in the body comes from the outside. So functional identical thrombinase can be produced in seconds. So the pathway bypasses the activation of your factor 9, as we have seen a while ago. 9, 12, 11, 9, and 8. Dr. Sajahan, your mic is open. So conditions triggering the extrinsic pathway would include abruptio placenta, amniotic fluid embolism, the presence of retained dead fetus, and those having saline-induced abortion. So showing you the algorithm of the extrinsic pathway, as I mentioned a while ago, it does not anymore go through your factor 12, 11, 9, 8. Instead, it goes directly to your, for the tissue injury, to your thromboplastin. Okay. So these are the conditions where you can see it. As I mentioned a while ago, abruptio, AF embolism, retained dead fetus, saline-induced abortion. Okay, so factor 7 is activated, okay, triggering the activation of factor 10 and 5, which again would activate your factor 2 to thrombin in the common pathway, and then later your fibrinogen present, it will be activated by the thrombin to produce a fibrin clot. So this one is shorter, the pathway is shorter, so it is more rapid. Okay? How about the abnormal platelet activation? So it is also known to initiate DIC. So the factors for platelet activation would be the release of platelet activator factor. The example is your thrombocytopenic purpura. Another one could be a deficiency also of prostacyclin, which is said to be a regulator or platelet activity. So preeclampsia may trigger DIC through this mechanism. So showing you the algorithm of this one. So with severe preeclampsia, your HELP syndrome or PIH, eclampsia, etc. Okay, there is platelet activation with your platelet activation factor and diminished prostacyclin. Okay, there would be an increased aggregation and adhesion of platelets, in which in turn would activate factor 10, 5, and with the presence of your calcium and platelet factor 3 in your common pathway, again, prothrombin or factor 2 is converted into thrombin, okay? And then with the presence of thrombin, it activates the present fibrinogen again to produce a fibrin clot. Okay. So what do you notice with the three ways of activating producing your fibrin clot? All of them would pass through the common pathway. Okay. Although they have different kinds of way in which the uh, mechanism could be triggered. Okay. So the end result would be a fibrin clot. So we go to the fibrin clot. So there's already your fibrin. Normally we have a fibrinolytic system. So the clot there inside could really not stay long. Okay, there should be a way where it should be or it should disintegrate. So this is a protective mechanism to thromboembolism. Okay, so this one, the algorithm for your fibrinolytic system, your plasminogen there with your tissue activator, urokinase, and plasma activator, okay, is activated to your plasmin. And then the fibrin and fibrinogen, okay, present your blood clots, is activated on by the plasmin to produce your fibrinolytic split products. Okay? So the clot should be disintegrated or what you call your fibrinolytic split products. Okay, and then it is slowly cleared out of the system, okay, after it is converted to your split products. Okay, we go to clinical features of your DIC. As I've said, there are early symptoms and there are late sequelae. For the early symptoms, you could have generalized macrovascular obstruction or like insufficient tissue oxygenation or the patient could be in shock. So microcirculatory damages in various organs can occur, like in the heart. You could have arrhythmia or cardiogenic shock, which we don't like. Lungs, you could have respiratory distress. For the central nervous system, patient could have tachypnea, fever, convulsions. For the kidney, you could have renal insufficiency. Skin, you could have infarction. And in adrenals, I hope we do not have that adrenal shock or your Waterhouse Friderichsen syndrome. For the consumption of coagulation factors and platelets, we could have generalized bleeding. For the more late consequences or sequelae, on the later stage, if you cannot uh, treat that in earlier, okay, if it continues, you could end up having organ dysfunction. Like in your kidneys, there could already be uremia. So when you request for laboratories like your BUN, CREA, it would be elevated. And if the liver is already affected, you could end up having jaundice and liver insufficiency. And naturally, you could have elevated uh, liver enzymes. Okay? And then again, your red cells could be destroyed or they could erupt and it could lead to anemia adding to the more anemia, and then you could also have with with your red cell destruction, you could end up having increased bilirubin in the blood and jaundice all over the body. So hemorrhagic diathesis or continuous bleeding occurs as coagulation factors are and platelets are consumed. Hemolytic anemia with jaundice is also a consequence, as I've mentioned, of RBC destruction. So frank bleeding, a tendency to bleed from the mucous membranes, your IV sites, the injection sites, and surgical incision sites. Okay? So if you see this, that even the IV site would already bleed, okay, it's highly that you are already in the later portion of your DIC. And that is what you don't want to happen. Abnormal bruising, purpura, petechiae, and ecchymosis, or your bluish discolorations in the skin. You could also have patients who would show melena or blood in the stools, hematemesis or vomiting of blood, hematuria, blood in the urine, and vaginal bleeding in severe cases. So actually, sometimes if they have profuse vaginal bleeding, the first thing we will think about is uterine atony. Okay? But then you see if we give already the uterotonics and the uterus is contracted, even though it's that they would still continue to have profuse bleeding. Okay? So it's really hard. Sometimes we have to end up in doing hysterectomy. Do we have to do hysterectomy or not? We have to decide because if we will further do operation, of course, when open up again, you will have another surgery, more bleeding would occur. So these are the it's really hard to decide. whether you will have to operate or not. Dr. Muhammad Sajan, I think your mic is still open. So, class, please check your mic if you are open or not. So, it's unfair to your classmates who are also listening. So, quantity and character of bleeding is related directly to the severity and explosiveness of the disease process. So, for our laboratory test, we have clot observation test. We can, if it's available in your institution, but actually, if you have the symptomatologies and you don't have the laboratory test there, it suffice that to diagnose it as DIC. So these are just supporting ways where you can diagnose it. You could also have your peripheral smear, and you would also note their anemia and the description of your red blood cells which are destroyed. Your partial thromboplastin time, your prothrombin time, fibrinogen levels if it's available, factor analysis. These ones are not readily available in our locality. Factor analysis, platelet counts or platelet noted in your peripheral smears can also be done. Another one is your uglobin clot lysis time, fibrin degradation products, which are not commonly available, serum bilirubin, especially if there's already hemolysis, and lactic dehydrogenase, because LAD would indicate possible red blood cell destruction. So, depletion of coagulation factors could be seen in your prolonged prothrombin time, prolonged activated PTT, low fibrinogen levels, decreased factor 3, 5, 2 if present in the lab, antithrombin 3 could be low or absent. For thrombocytopenia, you could note a low platelet count. Okay, remember in your health syndrome, we have mild, moderate, or severe health syndrome, or your class 1, class 2, class 3. Maybe you can have that as your assignment. What is class 1, class 2, class 3 health syndrome? And then abnormal clot observation test. Activation of fibrinolysis. You have shortened fibrinolysis time, elevated fibrin degradation products in the serum. And then for your microangiopathic hemolytic anemia, you would have fragmented RBC in peripheral smears, elevated from bilirubin, and management. Okay. So treatment is one of the most controversial due to varying clinical manifestations, and laboratory parameters are many. Sometimes they're not available in our locality. So they frequently change depending on prevailing coagulation defects and patient's response to therapy. So there is no hard and fast rules or set of protocols that will be effective in the management. So from time to time, your management for DIC could differ. Okay, you could add or decrease or change your management. Okay, so again, case-to-case basis, your good clinical judgment, recognition, and treatment of the underlying disorder prompts decision and adequate supportive measures, which are necessary tools in therapy. So antifibrinolytics, anticoagulants, and plasma products can correct only certain facets of the disease and can't be used all of the time, all of the same time. So management of TIC. So the cornerstone of therapy is correction of the primary pathologic condition. So in obstetrics, termination of pregnancy. But The question is, can we really already terminate pregnancy, especially those in having preterm babies or severely preterm infants? So again, you will have to make a decision whether to save the mother first, or if you can really save both the mother and the baby, then you have to have the perfect timing of delivery of the baby. So this is to facilitate the return to control of coagulation mechanism, especially if there is already uh, there is decreasing maternal condition. You don't want the condition of the mother to become more um, decreased, or severe. So we have to terminate pregnancy. So replacement therapy restores depleted factors and platelets. So you could request for fresh whole blood. It would restore blood loss and volume, and it also contains the uh, platelet clotting factors if you have fresh whole blood. Because if it's already the blood kept, most probably the some factors are no longer present there. So cryoprecipitate, if it's already also available, you can give that. It contains approximately 200 milligram fibrinogen per unit. Okay, so 100 antihemophilic factor units or factor 8 per bag given unit per kilogram body weight. So you have to compute, for the what how much cryoprecipitate you would give your patients. It is used to restricted to cases with significant bleeding due to factor depletion. So platelet concentrates also for severe thrombocytopenia. Okay. So what is severe for OB, obstetrics? So if it's less than 50, I think, and if it's symptomatic, you already have to give your platelet concentrates. Okay. So 1 unit should be given per 10 kilogram body weight. So if your patient is 50 kilograms usually, then you should at least give 5 units of your platelet concentrate. Okay? And you would entail, or you'll be needing a lot of blood donors for this one. So one important thing to consider is the availability of your blood donors. Okay? Even you want to uh, request for platelet concentrates, but if it's not available in the blood bank, you can also do anything. Especially now, it's pandemic. Rarely they have donate donors for blood. So if you know others who could donate blood, can do so. Okay. So other treatments, heparin. Okay. You see, it's a little bit of a controversy because as you see in our previous slide, there is hypo, coagulability. And if you again give heparin, the more that you become hypocoagulable. So giving of heparin would depend on the timing or the state where the patient is. So in cases of consumption coagulation and if clinical condition worsens. So you can give it as 10,000 followed by infusion of 10 to 15 units per kilogram body weight until the clinical lab and parameters is stabilized. Okay? And another one, your epsilon aminocaproic acid, which is an antifibrinolytic agent, can also be given if secondary fibrinolysis is present. So specific conditions, if you have abruptio placenta, of course you aim to replace blood loss first and evacuation of the uterus by, if if immediate delivery is not possible, if there's no imminent delivery, then you have to schedule for a cesarean section of the patient. Okay? Cryoprecipitate to replace fibrinogen factor 8, and then platelet transfusion to correct your thrombocytopenia in late sequelae. Okay? renal insufficiency and thromboembolic complications. Okay, you could look at which products, okay, are really decreased or what to replace. Okay, if you just have to give everything, especially just to save the patient. In IUFD, if DIC is low grade, you induce delivery of the fetus. Okay, or and then you could use heparin if there is progressive consumption. But again, you have to know what to monitor if you are giving your heparin. And then amniotic fluid embolism, this is really have a poor survival rate and we do not want this to happen. Okay, so you have to correct hypoxia and the shock. You can use heparin and anti-fibrinolytic agents. Again, weigh the risk to benefit ratio. You have to note which would benefit the patient better. And then you could have your replacement therapies with blood transfusion or blood products. For septic abortion and obstetric sepsis, of course, start with giving your antibiotics. Heparin may be given in fulminant course, but use cautiously. Prompt evacuation of the uterus and adequate replacement of depleted factors. For eclampsia, of course, you have to control the blood pressure. In the presence of thrombocytopenia and microangiopathic hemolytic anemia or hypofibrinogenemia, the use of heparin has no benefit. So we never use heparin if we are dealing with eclampsia. Okay. Again, you have to control the eclamptic state and hypertension. If your patient is having seizures, you give your diazepam for active seizures. And to prevent further seizures to occur, okay, the best treatment would be your magnesium sulfate. Okay, we give them initially bolus, and then you give them through your intramuscular injection. And then post-operatively, you can give it for 24 hours after delivery, okay, so as not to have another seizure or eclamptic state. For hypertension, of course, you have to maintain these patients on your antihypertensive drugs, okay, and monitor them well. Okay, rapid termination of pregnancy for eclampsia. Again, you have to consider also the viability of the fetus. You have to check for the age of gestation. If there could be a way, if there's preterm, to give you first your steroids, then give the steroids first, okay, before delivery of the baby. At least it could help in hastening the lung maturity of the baby. Okay? So as also help to help the baby survive. And then FFP, fresh frozen plasma, rather than platelet concentrate is preferred, especially in eclampsia. Okay? So when there is loss of balance, okay, you could end up having DIC or your consumptive coagulopathy. So again, the question as I mentioned in earlier, was it really preventable or non-preventable? Tawag ako. Okay, si Dr. J.C. Dane Lacking or Lacking, are you there? Dr. Lacking? Wala. Saan kaya siya? Arian Fernandez? Dr. Arian D. Fernandez?
Yes po, Doc.
Okay, so answer yung question. Is the DIC preventable or non-preventable? Yes, preventable or
Preventable po, Doc.
preventable. Okay. So complications like DIC, as you see, it is preventable kasi you have your triggering factors there, di ba? You have your three ways where it could be triggered. And if you prevent those happening, okay, then you could prevent occurrence of your more severe complication, your DIC. But how could you prevent? Paano tayo, how can we prevent? Aliana Jane, I like your hair. Aliana Jane Exala.
Yes po, Doctor.
Yes, how could you prevent? Ayun. Clinical scenario naman na tayo because you will be doctors going to your municipalities or your community medicine rotations. How could you prevent these things to happen?
Doc, I think we should monitor po or check the blood parameters of that.
When? Be more specific. If you are the doctor, okay, so you have a pregnant patient, so how would you prevent this to happen? So, ask tayo ng help. Christian Bautista, Bautista yung kanyang name. Dr. Christian. Dr. Christian. Doon na tayo sa clinical na gagawin niyo. We want to prevent this to happen. Okay? So how? Try na ba? Ngayon nilang mag-reply sa akin. Dr. Jean Laluan. Jean Laluan.
Yes po.
Yes. How would you prevent DIC to happen? Yung personally or as a doctor, how would you prevent in the future for patients to develop DIC?
For me, Doctor, since...
I can hear louder, please.
Hello po. Hello po.
Yes. Mahina. Pero sige.
Doctor, since episodes of DIC or cancers of DIC are preventable in when we prevent obstetric complications, I think we should identify pregnancies who are high risk in developing so that we can manage them earlier.
Okay. So, when do we, thank you for that answer. Shaina Sofia Andrada. Question. Questionan ko lang kayo. When do we identify high-risk pregnancies? Shaina. Sophia.
Hello.
Yes. When do we identify high-risk pregnancies? Kailan natin na-identify na high-risk yung pregnancy? Nawala yata siya. Okay, walang answer. Randolph de Guzman. Dr. Randolph, andiyan ka ba? Oh, when do we diagnose or note high-risk pregnancies? Kailan?
Doc, if the patient has high blood pressure, or
When do you do that? When do you identify that they would have high blood pressure, high-risk pregnancy, etc., etc.? Kailan?
during ano po, Doc, history taking.
History taking lang ba? Pag andun na yung patient mo? History taking saan?
During the physical examination po, Doc.
Physical examination when? At the ward? Do you think if the patient is already at the ward or in the emergency room, you could still prevent it to happen?
During the ano po, Doc, during the prenatal visit po, Doc.
Yes. So that's what I want to extract from you. Okay? So we identify low-risk, high-risk pregnancies during the prenatal period. Okay? When the patients go for their monthly prenatal checkups, you should be already able to identify if a patient comes to you and she's pregnant, should be able to identify yourselves that this is a low risk pregnancy or a high risk pregnancy. Okay? But you should be very cautious because patients who might come initially with low risk conditions at the onset and then upon further with the going with the pregnancy. So example, at 10 weeks, 15 weeks, the patient is okay. But after the 20th week where you know that we would have possibility of preeclampsia or eclampsia already after 20 weeks, then they develop elevation of blood pressure, they could have edema, they could complain of on and off headaches, okay, or other signs and symptoms, then you should further investigate on that, okay, and do your proper management, closely manage them or closely monitor them even before admission. Because once patient is already admitted and they have the signs and symptoms already of complications of your hypertension, then it's really hard to reverse it already. It's either sometimes we lose the baby or we lose the mother or we lose both. So we don't want that to happen, especially for DIC, because it's really hard already to reverse the condition if they're already in the later sequelae stage. Okay, ang hirap. Okay, sometimes uh, or most of the time, okay, they would end up dying, okay, especially if they're already in the bleeding diathesis stage where even the surgical site is already bleeding. There is no adequate amount of blood which could we already give that patient. And whatever we do, okay, that patient would eventually go and die. Okay, so it is your job, okay, as future general practitioners first. So remember, when you graduate, you have licenses, you will be general practitioners first. You cannot complain or you cannot tell your patients, even if you go into subspecialties, that you don't know how to manage or see a pregnant patient because this is so basic. That's why we all want you to know that OB is still basic for a physician to know, and you could help in the community by monitoring them, okay? And not only concentrate on your subspecialty or specialties because initially all of us are general practitioners or general physicians. Okay? So you should have to develop again your clinical eye. You should be very very good in history taking, okay, their history, okay, and getting their signs and their symptoms, and then you have also to do, okay, your physical examinations properly so as to detect earlier, even without your laboratory test, that this patient could end up having a high risk pregnancy. Okay? So any question, class? Any question? Did you sign the attendance sheet? So you are 107. Okay? Any question? Wala ba? Did you understand the lecture? Okay, so if no question, who will document the attendance? Because this is the only topic I will give you today. Next week we have 2 topics, I think, and it's longer. Okay, so anyway, I think your assignment for me is just the health syndrome, the classification of your health syndrome. So you know that there's such a class 1, class 2, class 3, and it will differ in the presence or the amount or the level of your platelet count. Okay? So leader, did you take the attendance already?
Yes po, Doc. The ward work leaders will be accounting for the attendance of their members. Tapos,
This is the Zoom of the office. Si Sir Eric din po magpo-collect.
Okay, but I already also sent you a form to sign for me, okay, just to check.
Yes po, Doc.
Okay, so if no questions, then can we call it a day? So nice
Yes po, Doc.
meeting again, all of you. I think this is second sem naman, di ba? We already met last time.
Yes po, Doc.
Okay, so we'll be meeting again next week. Same, please send me the link. Okay. And if no questions, then you may go. Good morning.
Thank you po, Doc.
Okay.